Welcome to Nursing 634, Pharmacology for the Advanced Practice Nurse. We're going to start this semester talking about prescriptive authority and role implementation, tradition versus change. You need to keep in mind that providing health care involves assessing health status, promoting healthy lifestyles, identifying and diagnosing normal and abnormal conditions, determining the causes of abnormal conditions, providing referral to healthcare specialists, selecting appropriate therapeutic measures, implementing treatment, and supervising or monitoring the patient on an ongoing basis. Traditionally, these behaviors have been the exclusive domain of the physician until about 1965, when other non-physician provider roles began to emerge. Physicians' prescriptive practice has influenced all other clinicians who gain prescriptive authority. But how did this practice emerge? States first began to enact medical practice acts in the 1920s to protect the public safety. Before that time, however, medical education and the competency of physicians were variable. Medical practice acts were broad, and physicians were the first healthcare practitioners to gain legislative recognition of their practice. Because of the way in which the medical practice acts were written, physicians emerged with an exclusive right to practice that gave them a permanent position in the hierarchy of healing occupations. Dominance of the physician in the healthcare hierarchy created a virtual monopoly in healthcare. Having obtained the exclusive right to practice, however, physicians also recognized their need for the services of other practitioners of healing who were useful to the physician and necessary to their practice, even if it required giving up some of their monopolistic control. To solve this dilemma, physicians extended their right to practice to a right from the state to control the activities of other occupations so as to limit what they could do and supervise or direct their activities. In doing so, the profession was able to establish organizational structures that preserved the distinct sphere of professional dominance and autonomy. The role of the physician has changed dramatically during the last 50 years. Driven by new technology, new procedures, and new medications, physicians have been attracted into specialty practice in greater numbers, leaving many of the primary care physicians vacant. Medicare reimbursement has fueled the growth of tertiary care. The emergence of non-physicians who claim preparation for and the desire to provide primary care services came at a time when there was a shortage of primary care services. Beginning in 1992, the Physician Payment Review Commission recommended radical changes in Medicare reimbursement methods. This shift directly increased financial reimbursement to clinicians who were providing primary care and thus indirectly created an incentive to attract more providers into primary care. The hope was that the numbers and the types of providers would be more evenly aligned with the numbers and the types of patients who required health care. Medical schools began to place greater emphasis on preparing primary care clinicians. Teaching methods shifted from the acute care model to include a greater focus on primary care. The hospitalist emerged as a specialist, relieving the primary care physician of the need to provide in-hospital care. Reimbursement began to reward the general practitioner, and all of these changes have resulted in qualified success, bringing increased credibility and recognition to primary care providers. However, there remained a disparity in the ability of physicians to meet the primary care needs of the population. Non-physician providers began to fill in the gap with increasing success. The non-physician providers who emerged during the 1960s and 70s were well accepted by their patients, delivered high-quality, cost-effective care, and generally increased the access of patients to health care. These providers continued to work cooperatively with physician providers, most often in joint practices. But what about research on prescriptive practice? Not surprisingly, the prescriptive practice of physicians in primary care practice has been thoroughly documented by the pharmaceutical industry. What medications physicians order and how many prescriptions are written are closely monitored. Studies have not only evaluated basic prescribing practices, but have analyzed the effects that multiple variables have on prescribing habits. In a 2008 study, studies have demonstrated that drug categories prescribed were dominated by 5 therapeutic classes: pain relievers, cardiovascular renal drugs, respiratory tract drugs, CNS drugs, and anti-diabetic drugs. Less research has been conducted on the appropriateness of physician prescriptive practices, although the literature suggests that some physicians may write prescriptions for problems that might well respond to many non-pharmacological treatments. Considerable numbers of prescriptions are also written for off-label or non-FDA approved drug use. The pharmaceutical industry has expended considerable research dollars on determining how best to influence prescribers to adopt a particular drug. This is because they would benefit from the prescribers using their medications if they could prove that it's effective and useful. Guidelines issued by the U.S. Food and Drug Administration in 2001 prompted the American Medical Association and the Pharmaceutical Manufacturers and Researchers of America to issue ethical guidelines that clarify the appropriate relationship between pharmaceutical companies and drug prescribers. These guidelines forbid pharmaceutical companies from giving to prescribers non-patient care related items. They also clarify the role that pharmaceutical companies can and cannot play in the continuing education of provider groups. Current gifts to healthcare providers from pharmaceutical companies are restricted, so that even pens are now forbidden. This is to ensure that the providers are not influenced by gifts and an unethical approach to prescribing the medications that the pharmaceuticals companies make. So what have been the problems in prescribing practices over the years? Difficulties documented over the years in prescribing have been remarkably consistent. The conclusions of numerous studies suggest, first, problems are created in writing up-to-date prescriptions because of providers' failure to keep abreast of changes. Information about new products and new research findings diffuse slowly into practice, and many providers are often wary about suggestions for change in the practices until they have some evidence of safety and utility, especially for medications. Physicians in solo or isolated practice often fail to realize that they are out of step with other general practices because they may not have had the opportunity for daily critical debate and exchange among colleagues. Few providers have had sufficient time to keep up to date on new materials and instead rely on drug advertisements and pharmaceutical representatives for information. Most information in pharmacology textbooks is outdated before it's even printed. The internet and smartphones now assist in providing up-to-date information, although the problem now is often too much information for the providers to read. Internet webinars, continuing education activities, interactive discussion boards, and research abstracts from international specialty conferences, along with the ability to obtain specialist consultations through telehealth, will dramatically affect how providers obtain and use information and whether it will make a difference in their practice. Another problem in prescribing practices is that pharmaceutical companies influence practice and provide drug samples. When the bulk of information coming to a provider is provided through bias, marketing sources, providers may have a difficult time evaluating the relative merits of competitive products. Intervention by the FDA over the years has limited the amount and type of pressure that drug detail representatives can exert directly on providers to encourage them to use their products. Requirements for a more balanced presentation of information about diagnostic and treatment methods have helped to upgrade the quality of valid information given to providers. Current guidelines are a step in the right direction, but also remain voluntary. A third problem, a major factor in prescribing practices, is due to the lack of time for the practitioners in all medical practices. The emphasis on making money in many health maintenance organizations has led to decreased time for patient encounters, leading to inadequate history-taking, failure to clearly define the problem, and an over-reliance on drug therapy. Another problem in prescribing practices is that consumers provide pressure to prescribe medications. Although the interest of consumers in the healthcare care is usually a positive trait, the demand of patients on the provider to do something has translated into an increased incidence of by the consumer on being given a prescription. The pressure has increased as a result of the widespread use of direct-to-consumer advertising on TV and in lay magazines. Giving in to these pressures has resulted not only in a society of individuals who tend to take a pill for everything, but also in the widespread overuse of antibiotics, and thus contributing to the problems caused by drug-resistant organisms. In an FDA survey of physicians' prescribing behaviors, physicians reported an increase in the number of patients who asked them to prescribe specific drugs. They report that 41% of cases they had to spend time correcting misconceptions of the patient. In 26% of the cases, the drug was not needed, and in 9% of the cases, the patient wanted the drug rather than another therapy that was ordered. More revealing was that research that showed that when patients asked for a specific prescription, most of the time they received it. Another problem in prescribing practices is that prescriptions are often illegible. Pharmacists reported great difficulty in accurately reading and writing of many of the providers. This has led to major errors in dispensing of medications as they try to determine what the providers might have written. The use of pre-printed prescription pads, fax machines, and computer-generated forms will help to decrease these problems, and the current federal mandate for electronic medical records and electronic transmission of prescriptions for Medicare providers will set the trend for other healthcare insurers. The Joint Commission has issued requirements for its accredited organizations to avoid using abbreviations for certain drugs, drug dosing frequencies, and how drug doses are written in order to reduce prescribing errors. Finally, another problem in prescribing practices is that providers may fail to detect or anticipate drug interactions. Lack of provider awareness about the influence of different drugs on the liver cytochrome P450 enzyme pathways has meant that drug-to-drug interactions have made many medications ineffective. Increasingly, pharmacy computer software and PDA programs can alert providers to these types of conflicts. Over 5 million times each year, one of the nation's largest real-time computer systems alerts American pharmacists that the drug combinations they prescribed could trigger potentially lethal drug interactions. The prescription warning system issues 45 million alerts annually. Many warnings are issued for drug interactions that have been well described in the professional literature, but the high numbers of prescription drugs per patient often makes it difficult for prescribers to remember these potential drug combination problems. An even greater challenge is the growing use of over-the-counter and herbal products. Often the patient's provider is unaware of this usage, and many of the products do interact with prescription drugs. These are many of the issues that we run into today, and it's important for you to be aware of these. Next, we're going to take a quick look at a historical review of prescriptive authority. We'll look at the roles of nurses and physician assistants in prescriptive authority. Traditionally, prescriptive authority, again, has been the domain of the physician and dentists. The impact of physician prescriptive authority and primary care practices on other types of providers is important. Research on practices of non-physician providers has demonstrated conclusively that they are qualified to provide primary care. Because of the importance of medications in treating medical problems and in providing the full scope of healthcare services required by the typical primary care patient, all providers must be able to prescribe medications. This is especially true in rural areas where only one provider may be available. As relative newcomers, advanced practice nurses, physician assistants, PharmDs, optometrists, and others have had to carve out their prescribing role legally over time and separately in each state. The largest new group to assume prescriptive authority in the past 50 years has been the nurse practitioners and the physician assistants. Obtaining prescriptive authority was one of the major benchmarks achieved by these new provider groups as they developed their new roles. If one is to understand some of the problems faced by these providers today, one must learn about the history and how their prescriptive authority came to be. For many years, the boundaries of nursing practice have been carefully constrained by state nurse practice acts that maintain that nurses do not treat, diagnose, nor prescribe. However, in the 1960s, we saw a critical mass of bored, talented nurse clinicians whose substantial scientific education had been underused and whose ideas about making changes in the role were spurred on by the consciousness raising of the feminist movement. This happened at a time when other healthcare personnel were being pulled into the Vietnam War and concern had arisen about how primary care healthcare could be continued to be delivered. This time was formative for the nurse practitioner movement. Although some educators decreed that the nurse practitioner movement as a cause designed to encourage nurses to leave nursing to become handmaidens to physicians, many nurses and some nursing leaders believed that this role would breathe new life into the profession of nursing, which it did. The nurse practitioner role and the physician assistant role parallel each other in the development during the 1960s. The two roles were initiated as the result of different factors but were fueled by the desire of medics and nurses in Vietnam to continue to practice in an expanded role in the healthcare field once they returned home. The role of MPs developed within the traditional nursing foundation. However, the PA role was defined under the guidance and advocacy of the medical profession. These two routes led to somewhat different experiences in role development and role outcome. The expanded role of the nurse did not begin with the nurse practitioner. Certified nurse midwives and certified registered nurse anesthetists had already established their own very clearly defined roles several decades earlier. The clinical nurse specialist trend in the education preparation grew out of the increased use of registered nurses in high-technology cardiac units, intensive care units, and dialysis units in hospitals at about the same time that the nurse practitioner role was being initiated in the primary care setting. While all of these roles had in common was that in each case, clinicians assumed some of the functions traditionally reserved for physicians. As such, they came to be known as advanced practice roles. So how did prescriptive authority for nurses evolve? Federal and state statutes and administrative law define control of drugs, including the act of prescribing. How these three elements work together to protect the public has evolved over time. Early regulatory precedents that gave primary prescriptive authority to physicians became a barrier to change for those new healthcare providers who sought prescriptive authority. Before the turn of the century, no laws were in place to govern the use of drugs. A myriad of elixirs, tonics, and pills that contained any combination of drugs, including opium and cocaine, were sold freely to anyone who was willing to pay the price. It was not until 1906 that the federal government enacted the first law, the Food and Drug Act, that prohibited alterated or misbranded food or drugs from interstate commerce. However, true drug safety was not effectively addressed until 1938 when the U.S. Congress passed the Food, Drug, and Cosmetic Act, which required drugs to be appropriately tested for safety and labeled with adequate directions for use. However, the explosion of new drug development in the 1940s made the labeling provisions difficult to achieve. Thus, the Durham-Humphrey Amendment of 1951 was implemented, creating a separate category of drugs known as legend drugs. These drugs were considered to be legend drugs if they bore the legend, "Caution, federal law prohibits dispensing without a prescription." These drugs did not require specific packaging labeling, but instead required medical supervision for the sale and use. This act also instituted the process whereby the pharmacists dispense legend drugs after first obtaining a written prescription from the authorized prescriber. The other major piece of federal legislation that affected drug regulation was the Comprehensive Drug Abuse Prevention and Control Act of 1970. This act limited prescribing, dispensing, manufacturing, and distribution to those individuals who were registered with the Drug Enforcement Administration, or DEA, an agency of the Department of Justice. It also classified narcotics and other drugs such as depressants and stimulants by their abuse potential, with differing levels of control assigned to each class. Some legend drugs were further classified as controlled substances and were placed under additional restrictions. Later on, we'll be talking about these, the classification of controlled substances and their use. The DEA will register individuals who may prescribe narcotics and other controlled substances. However, registration depends on the state authority to prescribe controlled substances. Consequently, only nurses working in states that grant authority to prescribe controlled substances may apply for and receive a federal DEA. Although the federal government has taken broad control over drug regulation, it has no control over who may prescribe, dispense, or administer drugs. This role belongs solely to the states and is generally addressed in the statutes, rules, and regulations that outline the licensure and scope of practice of specific healthcare providers. The state law that enables nurses to practice nursing is a legal statute titled the Nurse Practice Act. Nurses are individually licensed by the state in which they practice. In their efforts to protect a vulnerable and possibly ill-informed public in need of health care, every state has enacted licensing laws for healthcare providers. If people do not have the information or the ability to make safe judgments about the qualifications and ability of providers, the state serves as a proxy to gather this information through licensing. Although the state establishes a list of minimum requirements that one must meet to be licensed within the state, meeting the requirements does not necessarily guarantee that the provider is competent. Thus, licensure is a mechanism to protect the public that has not been conclusively demonstrated. Board of Nursing has been somewhat perplexed about how to make certain that they are protecting the public safety when the nursing role has changed so dramatically over time. In 1985, the National Council of State Boards of Nursing adopted a position paper on advanced clinical practice that called for regulations to be adopted in each state that mandates a minimum of master's preparation in a clinical nursing practice specialty to serve as the basis for advanced clinical nursing practice. The National Council of State Boards of Nursing also mandates recognition of national certification to identify nurses for advanced clinical nursing practice. However, it is clear that the use of national certification examinations established to provide professional recognition to obtain a license to practice in an individual state is fraught with its own problems. Whether traditional registered nurse licensure adequately protects the public when a nurse moves into an expanded role, or whether a second license should be given, is still a matter that is still being discussed. Nurses with advanced education want legislative parity with physicians who are not required to obtain additional license if they are professionally credentialed in another specialty. As a result of all these factors, wide variability is seen among states relative to who may prescribe and under what conditions prescriptive authority is granted. In addition, the degree of prescriptive autonomy and authority constantly evolves as new laws are passed and regulations are promulgated. Many have attempted to categorize the variations in prescriptive practice and authority allowed in different states as they're related to nurse practitioners. Essentially, two types of prescriptive authorities are afforded to nurse practitioners: delegible authority and authority legislated by nursing statutes or regulations. Delegible authority requires the nurse to perform under the direction of a physician, mandates the initial physician-patient relationship, and is legally based on medical practice acts. Delegible prescriptive authority can be further delineated into three subtypes: physician determination of patient-specific medications and authorization of the nurse to prescribe accordingly for the patient. Number two, standing order protocols that serve as instructions for prescribing. And number three, renewal of prescriptions by the nurse based on prescriptions initially ordered by the physician. Without delegated authority, the nurse cannot legally prescribe medications under any circumstances, but can recommend non-prescription medications. Although these categories were defined in the 1970s, they are still relevant today, and these differences help to explain some of the barriers to prescriptive authority that have been faced by nurse practitioners. However, this again differs in the state that you practice, and you need to become aware of what the rules are in your particular area. The second route to prescriptive authority that is legislated by the State Nurse Practice Act or by rules and regulations proposed by state boards of nursing and at times by medical and pharmacy boards. Two types of prescriptive authority are permitted in nursing legislation. The first type, dependent authority, requires that the physician retain ultimate authority through countersignature of prescriptions and or by written agreement between the nurse practitioner and the physician that outlines the need for nurse practitioner chart review, discussion, and oversight with the physician collaborator. This mode is similar to the delegated authority concept and is practiced in many states. Conversely, independent authority allows the nurse practitioner to prescribe alone. Independent authorities may still be restricted, for example, by excluding controlled substances or by limiting drugs to those listed in a formulary. Advanced practice nurses were referred to by a variety of titles, the most lasting of which are mid-level providers, non-physician providers, and physician extenders. The first educational program for providers who sought these new roles had varying names and curricula, awarded different credits, and prepared graduates who exhibited varying skills and competencies. In contrast to NPs and with their primary care focus, CNSs were educated for and practiced primarily in acute inpatient settings and specialty units. As such, although their practice was certainly advanced, they were not responsible for initiating the medical diagnosis and treatment of patients, but were true experts in nursing care. They provided advanced consultation and education and conducted research about specific patient populations. This group was frequently the most highly educated of the advanced practice nursing groups, in that a master's degree was almost mandatory for entry into the training. However, because they do not directly generate revenue, their role has been difficult to maintain. Initially, it was unclear whether there would be jobs for any of these nurses with advanced diagnostic and therapeutic training. It was also unclear if they could legally perform some of the tasks that they had been taught to perform. However, the educational programs that were eventually established were highly selective of their students and demanding in their requirements. Students were not allowed to graduate unless they could demonstrate a high degree of competence. Students were typically experienced nurses who were determined to practice nursing in a different way and wanted to make a difference. They were assertive and creative, and they were risk takers. Because of this combination of experience, competence, and assertiveness, these nurses earned support from patients and grudging acceptance from their physician colleagues. All expanded nursing roles enjoyed an uneasy relationship with medicine during the early phase of their professional development, and many physicians assisted in role development by teaching in educational programs and hiring new types of providers. These physicians clearly came to respect and support the accomplishments of nurses in the advanced practice role. Early antagonism changed to tolerance or acceptance. Then in the 1990s, new sources of hostility developed among physicians who had once been supportive. The American Medical Association began urging physicians to consciously limit further erosions of their turf, legislatively and professionally, and to view nurses with expanded roles who wanted direct reimbursement for their services as true competitors for patient loyalty and money. Nevertheless, because of the growth of acceptance of the nurse practitioner role and passage of legal authorization for expanded nursing practice in many states, educational programs thrived. The certificate programs that developed to prepare NPs gave way to university programs with the understanding that nurse practitioner education should be attained at the graduate level if it was going to withstand the criticism of physicians. Over time, universities felt the demand for more students who sought entry into the nurse practitioner programs. This led to the development of a multitude of master's degree programs with varying curricula, different standards, and questionable competencies. By 1995, with sudden media attention growing out of healthcare reform debates, congressional recognition of the NP role, and increased professional visibility for NPs, many other graduate nursing programs were emptying as students rushed to become nurse practitioners. This included many of those nurses with preparation as CNSs who were now seeking retraining as nurse practitioners. Capitalizing on increased demand, many faculties changed their admission standards to take advantage of the growing number of nurse practitioner applicants, some of whom had never even practiced as nurses before they elected to take on this new role. In 1996, the American Association of Colleges of Nursing released a document called The Essentials of Master's Education for Advanced Practice Nurses. The ensuing discussion and acceptance of recommendations in the Master's Essential Curriculum led to the notion that almost all nurses with master's degrees were advanced practice nurses. Thus, the term advanced practice nurses lost its ability to denote the CNS, CRNAs, CNNs, or NPs whose role had overlapped so much with the traditional physician practice. Those nurses who assumed tasks usually performed by physicians now were often described in business and industry as the nurses with diagnosing and prescribing authority. Clearly, all advanced practice roles have survived for longer than 40 years because the clinicians who have practiced within them were competent. Patients liked the blend of nursing with the expanded assessment and treatment skills of their new providers. The weight of evidence indicates that within their areas of competence, MPs and certified nurse midwives provide care whose quality is equivalent to that of care provided by physicians. Moreover, nurse practitioners and certified nurse midwives are more apt than physicians at providing services that depend on communication with patients and preventative actions. Patients are generally satisfied with the quality of care provided by MPs and CNMs, particularly with the interpersonal aspects of care. These new providers offered enhanced access to acceptable care, increased productivity, and cost-effective alternatives. These behaviors, combined with successful legislative efforts in each state to legally authorize the expanded practice of nurses, ensured survival and growth of the role. One component of role function with which each of these groups had to grapple, however, was prescriptive authority. Unlike CNMs or CRNAs, most nurse practitioners believed that they could not fully implement their role or provide services that patients required without being able to prescribe medications. The need for CRNAs and the CNMs to have prescriptive authority was less clear. Additionally, some aspects of CNS practice began to move away from hospital-based acute care services and to look increasingly like nurse practitioner primary care practice. These nurses also desired prescriptive authority. So, these types of nurses were required to amend the Nurse Practice Acts in all 50 states to obtain broader authority in their new roles and to gain specific authorization to treat, diagnose, and prescribe. Every state has since addressed this issue with great variability in the legislation passed. Opening up a Nurse Practice Act for revisions was essential, but often led to unwanted and unwarranted interpretation or regulation. Federal policy has established that only healthcare providers who are granted prescriptive authorities to prescribe controlled substances by the state can be registered by the DEA to obtain DEA numbers. In response to the growing recognition that states were authorizing nurse practitioners to practice and prescribe controlled substances, the DEA issued a rule titled Definition and Registration of Mid-Level Practitioners. The specific wording is found in the June 1, 1993 Federal Register and is provided for the registration of all mid-level providers, including nurse practitioners who are authorized by state law to prescribe controlled substances. To differentiate mid-level providers from other registered providers, the letter M precedes any DEA number issued to mid-level providers. In this way, the DEA has set nurse practitioners and other mid-level providers apart from traditional DEA registrants, such as physicians. The DEA considered this necessary because of the following reasons. First, the controlled substance authority granted to mid-level providers varies not only from state to state, but often from provider to provider within a state at the discretion of the board or of the collaborating physician. The different format registration number serves as an indicator to pharmacists and wholesalers to be alert to the probability that the mid-level provider controlled substance authority may be subject to specific state restrictions. Publication of this rule did not address two ongoing issues in many states related to the inappropriate use of DEA numbers. First, selected insurance companies require all prescriptions to include the prescriber's DEA number as a unique identifier for tracking and billing. And second, some pharmaceutical companies require providers to include their DEA numbers when accepting drug samples. These instances of inappropriate DEA number use has frustrated providers who normally would not find it necessary to obtain DEA numbers because their practices do not require controlled substance prescribing. Traditionally, pharmacists dispensed medication based on a prescription from an authorized prescriber. Federal law addresses the labeling and packaging requirements that must be followed. It does not exclude specific prescribers from dispensing medication. Currently, nurse practitioners in all states may receive and/or dispense pharmaceutical samples. However, dispensing is often limited to specific sites or circumstances. For instance, in some states, nurse practitioners may be able to dispense only samples of medications or may be limited to dispensing at sites located far from pharmacies or in specific types of clinics. Only a few states, such as New Mexico and Arizona, allow unrestricted dispensing of medications. Prescriptive issues still remain. The question of whether a prescription written by an authorized prescriber can be filled by a central distribution pharmacy located in a state other than the one in which the nurse practitioner is licensed had not come up at the time current laws governing pharmacy and pharmacists were written. Therefore, no law specifically addressed this issue. The FDA has issued but has not enforced guidelines stating that if a state recognizes a licensed prescriber and no specific regulation is against it, pharmacists in other states should recognize it as legal and fill an out-of-state prescription. However, many of these mail-order pharmacies refuse to recognize the legitimacy of an MP prescription. As more and more health plans direct their members to use online or out-of-state mail-order pharmacies to fill prescriptions, the problem arises of pharmacies refusing to recognize non-physician prescriptions and delaying patients of nurse practitioners from receiving needed medications. A search of relevant regulations suggests that only Texas pharmacy law may have some restrictions on whether pharmacists may fill an out-of-state prescription. Nurse practitioners as individuals and as groups are petitioning both the FDA and the Federal Trade Commission for support in requiring pharmacies to follow the previously established regulations and guidelines. Limitations on prescriptive practice can effectively restrict the public's access to affordable and comprehensive primary care delivered by diagnosing and prescribing nurses. Yet, despite the impact that prescriptive privileges can have on access to care, a great deal of research exists on prescriptive practice. What research has been conducted has most often focused on nurse practitioners who believe that not having prescriptive authority restricted their ability to deliver needed care. The first studies of nurse practitioner prescriptive practices were performed in the early 1980s. One of the largest studies was undertaken by the state of California in 1981 in an effort to guide future legislative initiatives surrounding prescriptive authority for nurse practitioners and other mid-level providers. After the prescriptive practices of more than 400 providers at 261 ambulatory practice sites in many underserved areas were evaluated, overwhelmingly support was revealed for prescriptive authority for nurse practitioners and other mid-level providers. All supervising physicians thought the providers were competent prescribers, and 99% believed that they had made the correct diagnosis. Patient acceptance was also high at 97%. Cost effectiveness was evaluated as well, and it was found that an additional $2.5 to $3 million would be necessary to provide the same level of patient services if additional time had to be purchased from traditional providers such as physicians. Furthermore, clinic administrators believed that medical services would be sharply curtailed or completely eliminated for significant population groups should prescriptive privileges be denied. And if you think if this was done in 1981, you can imagine how much additional money would be necessary at this time. A variety of studies over the years have documented the gradually increasing prescription rate of nurse practitioners, particularly expanding the numbers and types of medications for which prescriptions are written. One study based on a sample of 1,399 show the medications currently ordered by nurse practitioners to be fairly consistent with other studies on prescriptive practice of nurse practitioners over time. The data also demonstrated that nurse practitioners frequently recommend over-the-counter products. A total of 93.7% of nurse practitioners recommend at least one over-the-counter product per day, and 67% recommend 1 to 25 over-the-counter products per day. 73% of individuals in the sample had their own DEA numbers, 11% used a physician's DEA number, and 16% did not prescribe drugs that required DEA numbers. MPs who worked in employee health, occupational health, or pediatric clinics report that they had relatively low requirements for controlled substances, or they may be in the military or the U.S. Public Health Service and are exempt from DEA registration. In 10 years, the number of MPs with their own DEA number grew from 33% to 73%. The data also documented that nearly 96% of patients were treated with little or no MP consultation with physicians. The studies conducted over the years are remarkably consistent in their findings. NPs tend to order medications appropriate to their preparations as primary care providers and for patients across the age span. Nurse practitioners are shown to consistently order fewer prescriptions than are ordered by physicians. A synthesis of the most recent prescribing data suggests that the degree of prescriptive autonomy granted by legislative statutes and administrative regulations has great variability among states, and that overly restrictive regulations harness MP productivity and prevent MPs from making the full contribution to health care for which they are educated. Even with severe restrictions, the types and numbers of prescriptions remain relatively stable across regulatory environments, with significant variation noted only in the method used to generate a prescription. Thus, it is difficult to justify imposing strict regulatory limitations on nurse practitioner prescribing. This conclusion has been shared by an increasing number of state legislative bodies, despite consistent attempts by the medical profession to block legislative advances in prescriptive authority. And we do see this as more and more states are allowing for more mid-levels or advanced practitioners to prescribe independently. So what are the barriers to practice for nurses in the diagnosing and prescribing roles? Again, regulatory irregularities among the states, increased antagonism from organized medical groups competing with advanced practice nurses for patients, growing number of nurse practitioner graduates without prior nursing experience, inequity of data collection on physician prescribing patterns among pharmaceutical companies, and difficulty in obtaining prescribing data from the PDMA. So what about the physician assistant? Physician assistants are also healthcare professionals who practice medicine under physician supervision. As members of the healthcare team, PAs provide a broad range of medical, diagnostic, therapeutic, and preventative care services. PAs are qualified by formal education and are authorized by national certification to exercise a designated level of autonomy in performing clinical responsibilities within their scope of practice and supervisory relationship. PA clinical practices spans primary care and specialty care roles in a wide range of medical practice settings in rural and urban areas. In addition to the clinical roles, PA professional responsibilities may include providing healthcare services that complement physician services, such as health promotion and disease prevention, and or assuming educational research and or administrative duties. All states have specific requirements for the PA who is seeking entry into practice. Typically, individuals must be graduates of a PA educational program accredited by the Accreditation Review Commission for the Physician Assistant, also called ARC. And nearly all states require that they pass certification from a Physician Assistant National Certifying Exam, the PANCE. The National Certification Exam administered by the National Commission on Certification of Physician Assistants. Physician Assistant educational programs comprise intensive 2 to 3 years biomedical curricula emphasizing a primary care medical generalist approach. Nationally, PA educational programs do not award a single academic credential, although there has been a marked trend toward the master's degree. Traditionally, in PA education, the competency-based model of PA qualification for medical practice has been demonstrated by completion of an approved educational program and receipt of national board certification rather than by a process tied to a specific academic degree. This format has gained acceptance among medical licensing boards and occupation regulators, but pressures for a standard academic degree awarded for PA education has increased in recent years. Thus, a PA may receive an associate's, bachelor's, or master's degree for completion of PA educational programs, but more recently, most receive a master's degree. In 2007, 135 ARC PA accredited PA educational programs were available, an increase from 107 to 1998. More than 100 programs, many of which have been implemented during the past decade now award the master's degree. A shrinking number of programs continue to award the bachelor's degree or a certificate or an associate's degree. PA programs, which are sponsored by universities, academic health centers, medical schools, teaching hospitals, and colleges, graduate approximately 4,700 students annually. This was back in 2006. I'm sure this has tripled in numbers over the last few years. The mean length of PA training is 26 months and resembles a shortened version of medical school. Education typically is conducted in 2 phases, didactic and clinical. A PA didactic training usually comprises of 10 to 12 months of academic coursework with instruction in the basic sciences, anatomy, physiology, biochemistry, microbiology, pathology, and pharmacology, and in the basic clinical sciences, history taking and physical exams, behavioral science, clinical medicine, and diagnosis, including pharmacological aspects of patient management. Because knowledge of pharmacology is a required component of practice for the PA, ARC PA accredited programs must include formal course instruction in basic and clinical pharmacology. ARC PA standards mandate that PA programs must teach the principles of clinical pharmacology and medical therapeutics appropriate to the medical therapy for common problems in clinical practice. PA clinical rotations and preceptorships stress the appropriate use of drugs and medications as part of patient care management. A national survey of PA educational programs in 1998 revealed that the typical PA student received an average of 78 hours of instruction in pharmacology with a range of 28 to 128 hours. The National Certifying Exam for PAs, the PANCE, comprises of written multiple choice question component, the test item content and scoring standards developed by the National Board of Medical Examiners. This board has administered this exam since 1973, and certification is required for PA qualification in 49 states. More than 92% of the 60,000 PAs in active clinical practice in 2007 held the National Board, the NCCPA certification. PANCE question item content assumes that the PAs possess academic and clinical training in patient pharmacological management. On any given PANCE administration, 32 to 38% of the exam items relate to pharmaceutical aspects of patient care management. To meet requirements for continuing certification, PAs must obtain 100 hours of continuing medical education hours annually and must be recertified by formal exams every 6 years. However, this is going to be increased to every 10 years. 19 states require a PA to maintain ongoing certification, and a number of states have similar CME requirements for PAs to maintain state licensure. Some states require PAs to obtain specific CME credits in pharmacological patient management prior to being granted prescriptive authority. In general, there is empirical data on prescriptive practices of the PAs. The only significant study on MPAs prescribing was undertaken in a large health maintenance organization. In this study of primary care providers, the annual rate of prescribing was higher for MPs than for adult care physicians by 4%, and PAs were higher than those for the same cohort of physicians by 9%. Some of the differences could be explained by the type of care that was provided. MPs were providing a large percentage of wellness care for patients. PAs saw more acute problems than chronic ones, and physicians managed more complex patients. In one study, which analyzed data from the National Ambulatory Medical Care Survey from 1997 to 2003, found that prescribing patterns among PAs and MPs and primary care physicians were similar. This has continued over the years, and the MPs and PAs are currently in the same roles prescribing similar medications. Legislative process. Overly restricted legal stipulations on prescriptive authority have kept PAs from completely implementing their roles in many settings. Barriers to prescriptive authority increase the cost associated with PA utilization if a physician must be consulted, and may deter PAs from practicing in certain states and or serving medically needy population. Inconsistency in state medical practice acts, lack of prescriptive authority, and the absence of Medicare and private third-party reimbursement that affects many rural ambulatory practice settings have been shown to restrict PA utilization. The AAPA has developed model guidelines for state practice acts governing PA practice and prescribing activities to try to enhance PA practice flexibility and standardization among states. On the public policy level, barriers to practice that once existed now have been largely resolved. The medical, legal, and economic factors that formerly presented obstacles to PAs in performing the full range of clinical tasks for which they are both educated and certified no longer exist in most instances. States, through their health occupation licensing boards, have considerable control over the qualification requirements and practice activities of PAs, as well as those of physician and other non-physician health providers such as nurse practitioners. State authority in regulating PA and MP health providers permits boards to define provider scope of practice, determine physician supervisory requirements, authorize prescribing activities, and establish and enforce standards of professional conduct and disciplinary procedures. A number of clinical factors have been identified for which PAs could be better used in the healthcare service delivery. For example, the growing need for more providers to care for geriatric and nursing home care patients. Non-physicians were viewed as playing an increasingly important role in service delivery. However, a recent review of PA and non-physician literature on their utilization in geriatric care settings shows that not only being used as anticipated because of the many legal and regulatory barriers that limit the non-physician providers can do, including restrictions on prescribing authority. Delegation of prescribing authority to PAs has been viewed by some physicians as empowering PAs to establish patient relationships and reducing the power of the physician in that same relationship. Whether this desire to retain the sole privilege of prescriptive authority arises from the traditional power of the role or from economic or political factors, physicians have been reluctant to share this prescriptive authority with newcomers in healthcare. Regardless of the preparation of the new providers, it is difficult to make changes in the status quo. So many states have been willing to permit delegation of this authority to PAs and other non-physician providers attests to the success that non-physicians have extended in drug prescribing. In fact, no suggestion can be found in the research literature that non-physicians do not perform well in meeting the medication requirements of patients. A number of reasons have been advanced as to why state regulatory agencies have limited the prescribing privileges of PAs. One reason cited early in the development of the PA role is that PAs were not sufficiently trained to be competent prescribers. Further, because the agencies that regulate PA practice historically have comprised largely of physicians, concern has arisen about the potential of increased legal liability of supervising physicians associated with the practice of PA. Physician reluctance can also come from various cultural and/or gender biases. Other possible reasons why these agencies may limit or deny prescribing prescription privileges to PAs is the opposition of other healthcare professionals, namely nurses and pharmacists. Another possible reason for limiting prescribing privilege is largely economic. The initial purpose of developing the PA role was to alleviate a shortage of physician services. In more recent years, with the advent of more abundant supply of physician services, the distinction between whether PAs complement physician services or are alternatives for physician services is less clear. The later quandary over role function implies that PAs are currently viewed as being competition with physicians for patients. In fact, PAs maintain they do not compete with physicians, but instead work with physician practices to enhance and expand medical care services. So, to summarize, PAs as well as nurse practitioners, advanced providers, all seem to face the same issues for limiting of prescriptive authorities. As providers, we must be active in changing laws and working towards independence and autonomy so that we can provide the appropriate care for patients.